ask Dr. Stevenson to introduce our Grand Round speaker. But in the meantime, regarding attendance, we'll be taking the attendance in the standard ways around 8:10. And so if you're calling in or if your name does not appear clearly in the participants list, please let Michelle or Beth know about your attendance. And thank you. All right, with that, Dr. Stevenson, are you ready to introduce our speaker?
Yes, I am. Thank you. So I'd like to welcome Dr. Holtz to our Grand Rounds this morning. Dr. Holtz is the Division Director for GYN Oncology with Mainline Healthcare. He's the chair of the coding subcommittee for the SGO since 2021. He's also the SGO liaison to ACOG's Coding and Health Economics Committee. He graduated from Jefferson Medical College and completed residency at Jefferson University Hospital and was a fellow at the University of Pennsylvania. He was the first GYN surgeon in Pennsylvania to perform procedures for uterine and cervical cancer with Da Vinci robot. And he is a clinical assistant professor with Thomas Jefferson University Hospital and the Lankenau Institute for Medical Research. So I think, I invited Dr. Holtz for a couple of reasons. I missed SGO this year. So I am a medical director at the Rutgers Cancer Institute here. I'm one of 4 GYN oncologists. Unfortunately, a lot of us are away for spring break and the holidays and everything, but I think that this is a very important talk to have for a couple of reasons. My first job was in private practice, and I think that a lot of our trainees, don't really understand how to get credit for all the hard work we're doing in the operating room. So I think this will be important for our trainees and graduating residents. And then we've also transitioned to Epic in the last year at Robert Wood and Rutgers. And so I think a lot of us are now doing our own coding and billing, which has also been difficult. So I'm really looking forward to this talk. And I just want to thank you for coming. And I'll turn it over to you.
Thank you, Dr. Stevenson. It's a very nice introduction, and I really appreciate the invitation. So in 45 minutes, I'm going to try to make you all experts in coding for gynecologic surgery. Actually, that is impossible. So this is really just a taste, a flavor. This is your introduction from which you guys will have to move on from there. I do have a couple of companies that I consult for, but obviously they're not going to really have anything to do with this talk. This is the standard disclaimer we give at the beginning of all the SGO coding courses. So while you guys look at this, I'm going to give like 2 seconds of intro. This topic is not what you went to medical school for. This topic is not why you became a doctor. It is, however, really important for the actual practice of medicine, and potentially maybe even for a little bit of your satisfaction, since you will have less frustration with the business side. But this is just dipping your toes into coding. So forgive what I'm about to say here, because I'm not having a stroke, but I want you to understand procedure coding like a boss. I want you to use this information for huge financial gains, and I want you to flex on your coding and compliance bros. Now, why am I acting like an idiot? Well, first of all, this is such a dry topic that I don't want you guys to fall asleep. But second of all, as I was thinking about how do you present this, I realized one of my other things that I started early in my career, as well as coding, was weightlifting to prevent back injury and neck pain, which I had seen in a bunch of my colleagues. So there's a purpose for this talk, and it's not just to behave like an idiot. You guys are going to learn a new language. So this is sort of like the first time you enter a gym and people are talking about using, the pec deck, and they're exercising their lats, and they're talking about creatine shakes and all this craziness. There's a new language that you have to learn to discuss coding and compliance with the folks at insurance companies, and within your coding and compliance units at your hospital. Both take time. You don't go to the gym, flex those biceps a couple times, and expect them to pop. This is years and years. Same with coding. You need to expect this to be your first taste, and then you go back for some appetizers, maybe at the ACOG coding course, and then you have to keep doing it, on the daily. Okay, sorry. Consistent effort. So it's also not that it's going to take time, but it's something you have to do on a fairly regular basis. I when I am asked coding questions, go right back to the same textbooks I've been using for, well, not the same textbooks, the updated ones that I've been using for 15 years. You may need coaching. Okay, so nobody, does their first squat or deadlift on their own if they're smart. You want somebody watching what you're doing, and you may also need that for coding. Okay, you may need to go to your coding and compliance people. You absolutely should be taking courses, webinars, if you want to get at all decent at this. But the payoff is huge. And I'm not just talking about those massive guns. I'm talking about the financial payoff. And of course, this is both a positive and a negative. So let's talk a little bit about new languages. So like any new language, there are nouns. Nouns are the objects, right? So this is in medicine, this is the ICD-10s, the International Diagnostic Code number 10. This is maintained by the World Health Organization. By the way, today is the founding of the World Health Organization 75 years ago. So happy birthday, WHO. In any language, there are also verbs. So ICD-10 is very important. I have a whole nother hour I could talk to you about ICD-10, but I'm not gonna, because we're talking about coding. Procedure, that is the verbs. CPT stands for Common Procedural Terminology. And this is something that back in the, I believe it was like the 80s, CMS, which is the federal part of Health and Human Services that controls Medicare and Medicaid, contracted with the American Medical Association to come up with terminology, common terminology for procedures and for office visits. And these are all referred to as the CPT codes. There's like 10,000 of them. There's even more ICD-10 codes. So that's why having an app or having Epic, which can help you look these things up, is so important. With any good verb, of course, you're only speaking part of the language if you don't know adverbs, and we have modifiers which alter how the insurance company or how the coding and compliance person looks at your code, and it gives them additional information above and beyond just simply what you did. All right, so who are we talking to, and why are you talking to them in the first place? I mean, come on, you really want to take care of this person in front of you. You don't really want to worry too much about the bills. You'd like that to just happen, but unfortunately, that doesn't just happen. There's a process for it. These CPT codes I am talking to you about are Medicare codes. They are almost universally used by private insurers, but there are some exceptions. So everything I'm about to tell you applies to Medicare, which I think for a lot of OBGYNs is not the major payer. For Dr. Stevenson and I, this is a major payer for us. Most of our patients are older. A lot of them are going to be on Medicare, but private insurance companies also have adopted most of this CPT terminology. There are some differences, and so if you don't get frustrated if your coding person comes back to you and says, oh, well, you fill in the blank, private insurance company is not paying for this. There may be a reason. It may be that their rules are different. It may be that you're using a code that they do not recognize. You are also talking to your coding and compliance people. So you guys are at a large institution. You probably have a whole room full of folks who are trying to do the coding, but also to make sure that you're compliant, that you're not overcoding or undercoding, which can have a problem, which can cause its own problems, which is on the right-hand side. And then there are auditors, and auditors would be coming from the insurance companies or from Medicare. We really never want to see the auditors, but if you do see them, you want to know with confidence that you can support the claims that you are making, meaning that in your dictation of your case, in your documentation, that you have support for everything that you have done. Because there is a cost for failure. This is not just about getting paid. It's also about avoiding the pain that can come with failure. So there's, of course, if you're underbilling, you're not getting paid as much per case. And these can be substantial differences. The difference between billing properly for a hysterectomy, a laparoscopic hysterectomy, where there is a difference between uteruses that are less than 250 grams and uteruses that are greater than 250 grams is several $100s, and you may as well get paid for your time and effort. There's also the cost of time, and this is again something I never learned in medical school. I didn't even learn on the coding committee, but one of our coding committee members is in the coding and compliance department at Iowa University, and she gave a very nice talk on the billing cycle, which again would make your eyes totally glaze over if you have to spend an hour. But basically, the faster you get paid, the better off you are, because there are even instances where if things are delayed because you put in the wrong code, but you meant to put in the right code, or perhaps you forgot to tell the insurance company that you were doing a second procedure, and this should have been allowable, but the insurance company said, no, 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 this is a second procedure. We don't allow that. If this takes more than 90 to 100 days to get the billing clean, sometimes the insurance companies simply won't pay you. That may be part of the contract. So time is also a cost. And then there's the False Claims Act, which is a federal statute, which basically says every time you commit fraud against Medicare, you can be charged $11,000 per occurrence. So failure sometimes should not be an option. You can tell I had a lot of fun with this talk. So what is common procedural terminology? Again, the American Medical Association has the copyright for these 10,000 codes, and they sit together in committees where if you decided that you had a brand new method for shrinking fibroids or for making the cervix immune to premature delivery, you would go to the AMA and say, I have this brand new procedure. This is, a procedure that's done on the cervix, and we would like to give it a new name. And you have to support that with literature, and then people vote on it, and then there's a whole process. And then there's a whole nother process for getting it valued, but I'm not going to go into that right now, I don't think. So the AMA is the owner of the CPT codes. They are all published on an annual basis, and for $120 you can get your very own copy of the AMA CPT book, which has every single one. If you like a condensed version, ACOG does a OBGYN specific one. This is sponsored by CMS. I should say it's contracted through CMS. So the federal government gives the AMA some money to do this. There are too many codes to go through, but they are broken down into families. So for instance, if you're doing a delivery, your code is going to be 59 something something something. Okay, all of them are within the 59,000 code group. I happen to know, just because I do lymph nodes, that the 3800 code group is all lymph nodes. Okay, if you're doing skin surgery, it's in the it's in the tens thousands group. So they're all like coded together. So if you're confused, if you do a skin biopsy on somebody in the office and you're like, why did I do that? I have no idea how to code that. It's actually something that's fairly easy to look up on the internet. But if you had one of these books, you'd kind of thumb through the index and get to the right family. Within the gynecology group, there are families for cervical, vulvar, vaginal, uterine, ovarian, and ovarian cancer debulking. And then, of course, everything else that's done in medicine has a code. So every x-ray, every lab test, and every outpatient visit has its own CPT code. So this is your way of telling, this is the verb that you're going to use to tell the insurance company, this is what I did. They're all 5 digits, every single one. They all have a short descriptor. So if you go to the book, you'll have a short descriptor, but then you'll also have a long vignette. Now the vignettes will not necessarily apply to every single person, but they're supposed to give you sort of, this is the idea of what we wanted for this particular case. The short descriptors are important though, because if you want to bill for a certain code, you have to make sure that if they say, for instance, this is a hysterectomy with ovaries and tubes, okay, and you don't do you do the tubes but not the ovaries, you wouldn't be able to bill that one. Now that's a made up case, and I'll show you that later, because that's not the way the hysterectomy codes work. But you do maybe want to look at those short descriptors early on to know what's in them. It also helps to know what's in the short descriptor because when you're dictating your case, if you dictate to the CPT code, again, your life will be easier and you will not face the wrath of the auditors. Tell me more, my brother. Okay, so each 5-digit CPT code also has a value that's assigned to it. And this is where life gets really bizarre. We call these things relative value units. And unlike lawyers who get billed on time, unlike somebody in production who gets billed on widgets, we are billing based on relative value units, and these are not necessarily as understandable as you might think, because these go to another AMA committee called the RUC, the Relative Value Unit. Utilization Committee. I always forget what the U stands for. But basically, this is a cage match where everybody from the House of Medicine, so there's a representative for family medicine and internal medicine and surgery and pediatrics, OBGYN, ACOG has somebody who sits on the RUC. And then there are rotating members from some of the smaller organizations, and they literally fight it out as to what the code should be. And then CMS comes in and says, you know what? I know you guys said that it should be valued at this, but we're going to take the 25th percentile instead of the 50th percentile, and we're going to pay you less than this. Isn't that fun? So with every CPT code, there's a relative value unit, which tells you about how much you're going to get paid, you as the doctor. It also tells the hospital how much they're going to get paid. It tells you where you're allowed to do the procedure. It tells you things like, are you allowed to use a co-surgeon? Are you allowed to use an assistant? Is this a surgery where it's assumed that it's bilateral, or are you allowed to bill twice for a bilateral code? How about multiple procedures? Are you allowed to stack them up? And this is most important, but also should be going away in the next few years. How long is the period of time after the surgery where you're responsible for everything that happens as a consequence of that surgery? And we call that period the global period. And the global period always starts 24 hours before a procedure, but some procedures have a 0-day global period, and some procedures have a 90-day, and some have a 10-day, and it makes no sense at all what is what. So cone life conization has a 90-day global, and a laparoscopic BSO has a 10-day global. And why? Who knows? That's just the way it was. So I'm gonna let me just try to pull something up, because you can, anytime you want, go to the CMS website, and if you look for the Physician Fee Schedule RVU file, you too can download this whole thing. And I hope you guys are seeing this. You guys are seeing an Excel spreadsheet, right? Okay.
Yes.
Okay, good. So on this, it has every CP code known to man. It's got the short descriptor. And then it has all of this information that you could possibly want, including the work RVUs. Okay, and then all that other good information. If you scroll, global period, I just saw fly by, co-surgeons, assistant surgeon, bilateral surgery. So it takes a little bit of time to learn what all these columns mean. And let me tell you, this is as boring as it looks, but it's well worth your investment in time. Okay, back to the talk. All right, modifiers. So these are the adverbs, okay? So if you lifted weights, this would be a very funny joke, because that's a modified biceps curl called a hammer curl. All modifiers are a 2-digit code that are added onto the CPT code. Back in the day, this was actually filled out on a piece of paper. Now it's all digital. All of these indicate that something about the procedure is different than expected, but it doesn't change the procedure itself. So it's not like you did something different in the code itself, but there are circumstances you need to explain. And if you do these properly, it increases the likelihood that you're going to have a clean claim, and it'll go through smoothly, and you won't have to write letters and have somebody tell you that you should have done it differently. All right, so this is a partial list of modifiers, and I do not want you to memorize these per se. But if you were to do something that was more than you expected, and this is in the eye of the beholder. There's a certain amount of, you're going to have to justify it, but let's say you do a hysterectomy and there's, 2 hours of lysis of adhesions from that past myomectomy. We've all been there. But that's a substantial amount of work that you're not going to get paid for. You can't bill for lysis of adhesions at the same time of hysterectomy. But you can say, listen, I did increased work and I want to send you a letter and tell you. Or perhaps you did a staged procedure, and I have to do this on occasion where you do like a cold knife conization, but then you're going to do a radical hysterectomy, within the 90-day global period. You have to tell them that that radical hysterectomy is part of a planned stage procedure. And then the other one that's not on here that's useful is the 57 modifier, which is, if you have a person in the emergency room, you want to bill for that consultation, but if you're going to take them for an ectopic pregnancy surgery, you want to also be able to bill for the laparoscopy for ectopic pregnancy, and that's where the 57 modifier comes in. And that is decision for surgery on the same day of surgery. Okay, let's hit that gym. That woman is pregnant. Can you believe that? She's deadlifting 225 there. You can too. Okay, so a little warm-up set here. A perimenopausal woman, intermenstrual bleeding for 3 months. You guys know that that's unusual. She has a BMI of 43. Her PCP sends her for an ultrasound before she ends up calling you, and it shows a uterus with a thickened endometrial stripe. Concerning for a polyp because, can't have your radiologist tell you exactly what they think. So you take her for a D&C. Pretty straightforward, right? Okay. Well, there's a number of codes that could be used for this. Not really. I mean, when you read the descriptors, it makes sense exactly what you should be coding. There's hysteroscopy diagnostic as a separate procedure. But you did more than just a hysteroscopy, right? So then there's hysteroscopy surgical with sampling of the endometrium and or polypectomy. Now that's sounding familiar, with or without D&C. Okay, that sounds pretty good. Just to give you a little perspective, if you also did an endometrial ablation, all of this from 58558 is written in here. Hysteroscopy surgical with sampling of endometrium, D&C, with endometrial ablation. So if you did an ablation, but you also took out a polyp, you don't get paid for the polypectomy and for the ablation, okay? There's some assumption that procedures overlap. So you don't get paid for a diagnostic laparoscopy the same day that you do a laparoscopic BSO. You don't get paid for a laparotomy the same day you do an open hysterectomy. So some procedures are assumed to be part of a larger procedure. With every procedure, you have to describe what you're doing. And this is, again, the nouns, the ICD-10 codes. So you could put down uterine polyp. You could put frequent and excessive menstruation with irregular cycles. You can put down both. Now, I personally do not put down cancer codes unless I have a pathologic diagnosis of a cancer. That's not a hard and fast rule. For instance, we've got a patient with stage 4 GTN. We do not have a sample of that because if you ever wanted to do a biopsy of a uterus with stage 4 GTN, you will see bleeding the likes of which you will never see again. But we were calling that, we were using the GTN codes. But for the most part, if you know the diagnosis, use the diagnosis code. If you don't, you can use the ICD-10 codes for as close as you can get. My one caution would be there are undetermined codes. They all end with a 0.9. Don't use those if you can avoid them. Just be as specific as you can. But Dr. Holtz, what do I do if I need to remove a polyp and do an ablation? Sorry, my friends. There's these things called National Correct Coding Initiative edits. So pretty quickly after the CPT codes were developed, the very first thing Medicare realized was that people were double billing for stuff. They were like, ho, 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 we're not in the business of double paying for you doctors. So there are many codes that cannot be billed together. There's obvious ones, like I just mentioned, where you can't do a laparotomy and do an open hysterectomy because they're already paying you for the opening and closing with the hysterectomy. There are others that are a little more subtle, like why can't I do lysis of adhesions? Why can't I bill for lysis of adhesions and bill for hysterectomy? Well, the rationale for that is lysis of adhesion, Medicare thinks they're paying you for the opening, the closing, the lysis of adhesions. You're paying for the opening and closing for the hysterectomy too, but for hysterectomy, some people will have adhesions and some people won't. So Medicare is assuming in that work RVU that they're giving you that there are harder cases and there are easier cases, and you're kind of getting an average of that. Anything that is checking your work, so those cystoscopies that we perform after a hysterectomy, but there's nothing wrong with the patient, that's checking your work. So you can't get paid for that. And then there are other things that are medically or surgically standard of care. I don't think we have a lot of these in OBGYN. So I'm going to sort of skip that. But if you were to check and allow me to go one moment to another spreadsheet, which again you can download. This is what you would see if you looked up the NCCN edits, and these come out every 3 months. You would see a CPT code for one procedure. You'd see a CPT code for another procedure in another column. And then over here, it would tell you why you can't get paid. Misuse of column 2 code with column 1 code. Remember, this was all developed back when these were published in booklets, in pieces of paper. So for computers, it's a lot easier to do these searches and check it. But this is just, I think in this case, the column 1 code and the column 2 code just don't make sense together. So there's a lot of reasons why they won't pay for things. Standard of care, surgical practice. This would be like, exploratory laparotomy is standard of care with a hysterectomy. So, but some you can. So I've got some examples of some codes that you can build together. You just may need to do it properly. Okay, back to work. Okay, case 1, part B. So you get complex hyperplasia, but no atypia. You put them on progesterone therapy for 6 months, and this time around, you can send her for DNC, but she thinks she's having hematuria. Now you do have 2 diagnoses, and it turns out that hematuria is an indication for cystoscopy. Same with if you were doing a hysterectomy and you saw blood in the Foley catheter or whatever urine you're getting, that would be an indication to do cystoscopy, and then you could bill for it. When you bill for 2 procedures, you have to tell the insurance company that you're doing this, and you do this with something called the 51 modifier. But because you've already positioned the patient, you've brought them to the operating room, you did an H&P, you did all that prior work, and you've got all the post work from the DNC, Medicare is not going to pay you for the full amount of a cystoscopy. They're only going to pay you 50%. Okay, and this is for every case that gets a 51 modifier. All right, this is crazy, right? You do the work, you should get paid for the work, but unfortunately, these are the rules we live with. So we just gotta work within it and do the best we can. Okay, another case, a case where you need a spotter. So let's say you take somebody for an open hysterectomy, they got a big uterus and they start bleeding, and so you're getting a little nervous. Maybe they assigned you the intern or the 4th-year medical student. Again, we've all been there. You start to get a little panicky because the bar was heavier than you expected. The pelvis is welling up with blood. So you call your partner. Now, this is a hysterectomy code that you guys will memorize, within the first 2 years of practice. 58150 is a straight up open hysterectomy. I put down the short descriptor without removal of tubes, without removal of ovaries. So you get no play for removal of ovaries in this open hysterectomy code. There's nothing for you there. It is worth, to put in perspective, 17.3 work RVUs. This past year, Medicare and the federal government, I think, was paying about $35 per work RVU. This is something that, if you're interested in politics, every year around November, December, you can call up your senator and representative and say, hey, could you please not cut our salaries by 8% next week? And sometimes they do and sometimes they don't. But that's work RVUs to give you some perspective. Okay, so you called your partner though. Okay, so another surgeon had to come in, taking their time away from something else, and providing value for your patient. So how do you make that work for you? Okay, well, there are codes for an assistant at surgery, and there are some very specific rules for this. So a -80 modifier with that 58150 code, your partner would bill that. So that would be saying to the insurance company, listen, we don't have a residency program. I needed to have an assistant surgeon. It's important that you, as the surgeon, indicate why an assistant was needed, retraction, suction of blood, packing, closure, whatever it is. But you want to indicate why an assistant is necessary. But what happens if you work at a residency program? Hey, residents, do you guys know how much you're worth to your hospital? You guys are worth like $120,000 a year. No lie. In fact, that's probably an old number. I suspect your residency director could give me a more up-to-date number. But Medicare pays for you guys to be trained, okay? And because they're paying for you to be trained, they don't want to pay again for an assistant at surgery. So there are times where you can justify an assistant even though residents are there. Protected education time is one big reason. The other one is no qualified resident is available. Again, if you get the intern, but this is a chief level case, you could justify having a second surgeon come in. You only get paid 16% of the work RVUs for the case, but it's better than nothing. Again, justifying the note, and if you are at a residency program and there was a resident available and you decided to use an assistant, you have to explain why. It can just be a one-liner, but I've got a dot phrase in Epic that does this for me, and it says either protected education time or no qualified resident due to complexity, something like that. All right, but what happens if you need those big guns? Okay, you need the gyn-onc. Okay, now you've got somebody who's a different kind of surgeon. You're a gynecologist, GYN oncologist, general surgeons. We all have different NCI codes than general OBGYNs do. So we're considered kind of a different thing. If I step in to do a hysterectomy, and I do a substantial portion of it, okay, so let me first say off the bat, I respect what general OBGYNs do. I'm there to support you guys. But if I'm there for, a 3-hour case and my office hours have just gotten, put on hold for 3 hours, we're going to be sharing this one. But how do you share? How do you tell the insurance company that you had 2 surgeons and you needed to share? We got a modifier for that too. It's called the 62 modifier. Everybody gets, the whole case is billed at 125%, and each of you get 50%. Both surgeons have to dictate a note. Both surgeons have to round on the patients. Both surgeons have to do work. And me as the GYN oncologist, I have to justify I justify in my note why I'm there. But this is how, if you call in a surgeon, this is how they might bill things if they're not doing something completely separate. So now if you call me in because you have lacerated the small bowel and I resect the small bowel, all I'm going to do is bill for the small bowel resection, and that's a completely different procedure code. That's a completely different, weightlifting exercise, if you will. So we're both able to bill. You're able to bill the hysterectomy. I'm able to bill the small bowel resection. But if we just do a hysterectomy together because it's very complex, this is how we would deal with it. Okay, 15 minutes. How about those tubes? If you can't read this, it says OB Gym. It's very funny. My son gave me this T-shirt. So this is where ICD-10 codes really matter. Oh, I'm sorry, guys. Okay, we'll get off of that one. And the reason they matter is because there are codes for prophylaxis, where you're prophylactically removing an organ, but Medicare only lets you do that once, okay? And sometimes we're removing tubes and sometimes we're removing ovaries in this day and age. Sorry about that. So you could also justify removal of the tubes and ovaries with family history codes, with personal history codes of cancer. What procedures do we use? Well, there's slight differences here. So laparoscopy with full duration and transection, which does reduce the risk of ovarian cancer 50%, still a great procedure. That will net you about 5.9 work RVUs. If we resect the fallopian tube, however, this falls under the 58661 code, which doesn't differentiate between removal of the tube or the ovary. So if you look at the way this is structured, is laparoscopy with removal of adnexal structure, parentheses, partial or total oophorectomy. So this is where you'd get your ovarian cystectomy. This is where you'd get your partial oophorectomy and or salpingectomy. So laparoscopy with salpingectomy is billed with this. You can, if this is not a bilateral, this is a bilateral code, meaning you can take out the left tube and the right tube and bill with the 50 modifier. What is going on here? And you will get paid a little bit for both. You get paid 150%, not doubling. So this would actually, if you got both, it would net you about 17 work RVUs. How about open? There is an open code for salpingectomy. This is a code where you can't use the bilateral. It's assumed you're taking both out because this one was designed for sterilization. And if you only removed one tube, that would be silly. And then there's a specific code for postpartum sterilization. Now, this is assumed it's in the same hospitalization, so you don't get quite as many work RVUs. And if you did it more than 24 hours after the delivery, you would need to use a modifier to tell them that this is part of a staged procedure. Okay, I don't expect you to memorize this. I hate slides like this, but this is just to show you the family of laparoscopic hysterectomy codes. This is supracervical and vaginal hysterectomies. You'll see in here that unlike the open code, where it's agnostic to how large the uterus is and whether or not you take the ovaries out, these actually note the tubes and ovaries. These note how large the uterus is. And this is hysterectomy. Now, all of these have the tubes and ovaries because this was a talk about salpingectomy. Okay. So if you were doing a prophylactic removal of the fallopian tubes, then you would just want to call it an encounter for sterilization because you don't want to block the surgeon down the line who's taking the ovaries out for prophylaxis. And then you would use the removal of adnexal structures. And I just want to remind you, today, 2023, even though it does decrease the risk of ovarian cancer, salpingectomy by itself is not considered prophylactic surgery. So if you have a BRCA patient, just counsel them wisely. Okay. Now, if you are removing the tubes and the ovaries, now you can use the codes for prophylaxis. So the Z15 codes are genetic predisposition for cancer, fill in the cancer, and the Z40 codes are prophylactic removal of an organ, fill in the organ, and then you'd use the bilateral modifier along with the laparoscopy removal of adnexa code. Okay. Whoops, oh, sorry. Okay, so let's talk about adding codes to codes because the only way to get big in this world is to lift the heavy weights, and the only way to get big codes is to stack them. So let's say you're taking somebody and they want a bilateral salpingectomy for sterilization, but they also have a Bartholin's gland, and they're like in their mid-40s and a smoker, and you're a little concerned, so you're going to take the whole Bartholin's gland out. Okay, so there's a code for salpingectomy. We talked about it. And there's the 50 modifier for because you're doing this bilaterally, and that's great. Actually, you know what? I have just found a mistake. This should be 58661 because who would do this open? You'd do this laparoscopically, and then you'd use the bilateral procedure code. So, but then there's a separate code for excision of the Bartholin's gland. It's not worth that much. I mean, it's like 5 RVUs. You would have to add your multiple procedures, but when you add up the whole bit of work, you're getting like 21, 22 work RVUs. That's pretty big. That's like getting up near, it's not quite radical hysterectomy land, but it's pretty good. It is awesome. Like her. This is, by the way, the silver medalist from Britain for weightlifting in 2020. How about a heavy lift? So for this one, I apologize. I had to go to the world of oncology where we get to add like code after code after code sometimes. So you get somebody with a prior hysterectomy and they've got a pelvic exam and an elevated CA-125, omental caking. So you throw in a laparoscope, and then you do a robotic resection of the tubes, ovaries, the mass, the omentum, pelvic and periodic lymph nodes, and maybe you even do a laparoscopic appendectomy, and it's all for ovarian cancer. Okay, so there's a bunch of issues here. Laparoscopic surgery, that's just part of robotics, right? So you don't get a separate code for that. So like if I do a laparoscopy and then convert to open for ovarian cancer, I don't get to bill for the laparoscopy. It's just that's kind of checking work. It's inherent. BSO and debulking, there's no laparoscopic code for that. Okay, and you cannot use an open code for a laparoscopy and vice versa. Okay, that's a rule. So we have a code for laparoscopic pelvic and periodic lymphadenectomy and omentectomy without a hysterectomy. This is a code that was designed for GYN oncologists to step into a case that an OBGYN is already doing and to do staging. The problem is you're not allowed to bill for a hysterectomy at the same time. So this kind of goofs up what we do now in modern practice. How about total laparoscopic hysterectomy, BSO nodes, and debulking? Well, we've got a code for that, but we didn't do a hysterectomy. So now we have to use something called the 52 modifier, and I'm going to explain that in a second in the last 6 minutes that I have. And then laparoscopic appendectomy is its own code, okay? So 2 things. 52 modifiers. I promise you this is like one of the last slides on modifiers, but 52 modifier is an important one. So if you do something, but for one reason or another, you judge you can't do all of it, like they've had their uterus removed, or it's not safe for me to take out the left pelvic lymph nodes, I'm going to cause a vascular injury. Okay, you have to tell the insurance company, yeah, I know I was supposed to take out those lymph nodes, but I didn't. And you add the 52 modifier, and it's called reduced cervical services. The problem is Medicare will take somewhere between 25 and 50% of the value of the surgery for that. Now you can appeal and say, oh, you know what, all it took was this was like 5 minutes of the surgery. This wasn't a big deal, but you're going to lose something. Okay, add-on codes. Add-on codes is another important one. There are specific codes that you cannot use all by themselves. And the good example for OBGYNs is the cesarean hysterectomy code. This one, if you look in the CPT book, has a little plus sign next to it. That means that it is designed to be added on to another code. It can't be used by itself. You must bill it with a cesarean. You must bill it with a delivery code. Okay. It's only worth 8 RVUs anyways. There's no global period. It gets the same global period as the cesarean section, but you don't have to do a separate note for it, and you don't lose 50% because it's a multiple procedure. So you don't use the multiple procedure modifier on this, the hyphen 51. Open API at the time of other major surgery is one I use periodically. You have to justify it. Okay, I forgot to put in the RVUs. I think it's like 2.5, something like that. It's not very much. So you stack them up, okay? And this is how you get those massive gains. Okay, so here's an example for you. This is several ways you could code this. Just as a example at the top, we have the open BSO debulking code, which gets you 27 plus work RVUs. So this is to give you a ballpark of idea of what this kind of work should be worth. So if you did the TLH BSO nodes debulking and you got a 50% reduction off of it, that one in total is worth 32.6 work RVUs. So you'd only get 16.3 with a 50% reduction. If you were able to talk Medicare into only a 25% reduction, that would get you 24.45. That's pretty good. If you just code for the laparoscopic BSO, because you can do it bilaterally, so if you code for the BSO and the omentectomy together, okay, you could get up to 31. So sometimes you have to play around with these numbers to figure out what's the best deal for you. So it turns out that even though you did all the lymph nodes and the omentectomy and everything like that, you might be better off with 2 different codes. And then the lap appy gets you another 4.5. Okay. So let's just whiz through the last couple. So you have time for questions. Cervical cancer patient. So this is a stage procedure. So you do a cold knife conization. You're going to deal with the cold knife conization code 57520. It nets you 4 and a bit work RVUs. You get your final pathology, instant invasive cancer. We can debate whether open or robotic is proper for the radical hysterectomy or all that stuff, but there is in fact a radical hysterectomy code. However, this cold knife conization has a global period of 90 days. So you have to tell the insurance company, yo, man, I know, but this is a stage procedure. Please let me do it. If you did everything for this radical hysterectomy BSO, by the way, it's with or without tubes and ovaries, but there are some descriptions in here that are really important. Okay, so one of the descriptors is a total pelvic lymph node dissection and a periaortic lymph node sampling. Okay, that's thing one that goofs us up, because nowadays I do sentinel lymph nodes, as does I think a lot of GYN oncologists around the country, and CPT has not caught up to this. So the other thing is, it also says upper vagina and perimetrium, and you have to dictate this or your insurance company is going to say, you didn't take the vagina, but that's part of the code. We're not paying you at all. Okay, this gets you 30, almost 31 work RVUs. Awesome for 3 hours of work. Super heavy lift. How about that ureterolysis? I get this question every single flippin' month. So ureterolysis is the CPT code for it is designed for one disease that the urologists see. It's for upper abdominal fibrosis. It is not designed for what we as G1 oncologists do with the ureter. So you're just never going to get it paid for. If you have true retroperitoneal fibrosis, you might be able to justify it. But it is inherent to any procedure. And most of the time, you're simply protecting your work. It's not part of the procedure itself. So suck it up, Buttercup. Okay, so finding your personal best code. Again, your best one's the radical hysterectomy. Sample the periaortic lymph nodes. If you did sentinel lymph nodes, just expect a 25% hit here at best. Okay, so a few words on modifier, and then I'm only a minute or two over time. So this is a second set here, which is where you rake your big gains. So just a quick review of some of the minimally invasive procedures that we use to show you what the values are. A lash gets you somewhere between 12 and 15 for leaving the cervix. You really only get a couple more work RVUs for removing the cervix. As a GYN oncologist, I would say take the cervix out. Do me a favor. It is miserable to do a radical trachelectomy. If you did the tumor debulking and omentectomy, let me tell you, it is a lot of work to do that, so it's fully justified. So who came up with these values, by the way? The answer is the OBGYN community did. So remember how I told you the work RVUs are done by committee? Well, part of that work, part of determining it, is a survey that goes out to all of the people who do that procedure, meaning you and me. And this occurred actually just before I became an attending, so I can't be blamed for this. But there was a big survey of laparoscopic hysterectomy codes. And remember how I said you're getting paid for your hardest case as well as your easiest case, and you're supposed to like go somewhere down the line? The only people who seemed to reply to the laparoscopic hysterectomy code survey were these folks who thought that they were the leading lights of, and they were like 50, I do like a hysterectomy in 15 minutes. Well, maybe your best one, but you're forgetting about your fellows time, prepping the patient. You forget about wake up time. You forget about talking to the patient in the holding area. You forget about all this stuff. So we basically did this to ourselves. Hysterectomies used to be worth a lot more, and they dropped by almost 33% overnight because people were not filling these out. So if you ever get an AMA survey, take it seriously. Look at your times. Really think about the amount of time it takes you to do your work for your hardest case as well as for your easiest case. So, bro, where do I find this sick info? AMA website. So the AMA does a course for $100. ACOG does courses, webinars. You can do it while you're lifting. It's awesome. All of CMS's information is for free on the cms.gov website. If you have a serious question or need to review your whole practices program, there are consultants who do this. I can hook you up. And you got to hit those codes daily. So like if you do a case, you should take 30 seconds and just Google search CPT, whatever the case is, and find out what you could be doing for it. So Lifting Yoda's got some take-home points. Yeah, that hurt. It's wise to start now. Start when you're young. Patience and constant application you need. Help you need from others. So ask for it. Call up your hospital's coding and compliance people and say, yes, I just have this question. Can you help me out? They live in a small, dark basement. They love talking to people. Slow, steady gains. Okay, so if you do this on a regular basis, you'll start to remember the codes. You'll start to understand some of the subtleties, but you won't understand it the first day. Mastery you can achieve. All right. I thank you for your attention and hope you have some questions.
Thank you, Dr. Holtz. Thank you for that excellent review. I see Dr. Ayub has her hand up.
Hi, good morning. Thank you for a great talk.
Good
I
morning.
have two questions actually. So you mentioned that cold knife cones have a global period. Do you know off the top of your head leaps if they have a global period?
They do. They have a 10-day global. And it's,
10 days,
again,
great.
one of
Okay.
those weird things. I will tell you that if you can get your hands on the 2022 ACOG OBGYN coding manual, I think the 2023 has it also. They have all the global periods in there. So I'm not shilling for anybody. I don't get paid for any of these, but I will say that ACOG does a pretty good job. And for 120, it's either 100 or 120 bucks. It's a really good purchase. And I bet your coding and compliance people have an old CPT manual they would slide you. But the AMA manual does not have any of these work RVUs or the global periods or anything in them. So the ACOG's the way to go if you want a quick, easy reference.
Okay, great. And then my second question is when you put in the 51 modifier for multiple codes, do you put it into each of the billing codes? So like, for example, I'm going back into my hysterectomy from this week, and
Okay.
I have 2 codes for her. Do I add the 51 modifier for each of the codes or just for the separate one?
No. Yeah, you don't want to do that. So whatever is the major code, the code that bills the most, and this is again where you might need to look this up because if you're not sure, you should look it up. But what was the other code besides your hysterectomy?
Just IUD removal.
IUD removal and
Yeah,
hysterectomy? Yeah, you're not going
yeah.
to get paid for that IUD removal. I can promise you that's going to be inherent. So, but you would just put for example, you would just put the 51 modifier on that code that is minor and only bringing in like 1.5 RVUs. So.
Okay, great. Thank you so much.
You're very welcome. So yeah, again, as an example, when I bill like ovarian cancer debulking plus an open appendectomy plus a splenectomy plus a low anterior resection, actually low anterior resection bills the most. So that's the #1 code. That has no modifiers to it. The appendectomy code has a little plus sign. That's an add-on code. It doesn't get any modifiers either because of the rules for add-on codes. But then everything after that's going to get a 51 modifier.
I see that Dr. Goldberg has his hand up.
Thanks, Dr. Ebert. Thanks, Doctor, for a terrific talk. I just wanted to say I'm doing this, I'm part of the medical school for over 30 years. And this is the first time that I remember having any lecture dealing with CPT and ICD-10. The residents don't know a lot about them. Medical students know even less about them. So I think I'm really happy that you had this opportunity to talk to us about this. It's very complex. It seems simple, but it doesn't even seem simple. It seems ridiculous. And we didn't even talk about office codes and whatnot. But anyway, I
Not an
really
hour?
appreciate this. Yeah, no, I know. But thanks very much. I think we all have to awake to what's going on because it is money in our pocket, even if we are employed physicians, even our, some people's bonus structures may be related to this. And so it behooves them to learn this as well as you seem to know it.
Well, first you should thank Dr. Stevenson. I haven't even been asked by my own residency program to do this, but I'm going to offer it. And you were absolutely right. This is very confusing because this isn't why we went to medical school. This is kind of like where law meets medicine. And I think very few of us have an interest in both. I'm actually not that interested in the law side of this. So, but thank you for your kind words. I appreciate that. However, I'm also going to put a plug in again. This is a little bit of politics, particularly at the level of Medicare, Medicaid. And if you guys are not writing letters to your congressmen and your senators and making them aware that you are feeling pain points, even if you're a salaried employee, if Medicare takes away 8% like they tried to do this year from what they are paying physicians, and by the way, they're only taking it away from physicians. They're not taking it away from the hospitals or the drug companies. It's just us. So if they're allowed to do that, that's the salary of a nurse or a PA. And think about how miserable your life would be if you had one less MA in your office or one less nurse to work with. So this has serious consequences for your quality of life, if not for the amount of money you have in your pocket.
And I think also, you know, there's been also some talk that a lot of the procedures that have to do with women are undervalued compared to a similar procedure that you do on a man. I don't know if you
Yes.
can comment on that.
I actually, our current coding fellow, who is just a fellow in GYN oncology, published on this, and we're trying to work on a project. Unfortunately, ACOG's past check president thought that he looked into this and didn't think it was an issue. So it's something that is certainly being looked at very carefully. But I happen to agree. I think that, you know, a lot of specialties that are dominated by women seem to get paid less. A lot of specialties that get dominated by men seem to get paid more. So
I see that Dr. Ayub has her hand up.
I have another question. When you do your hysterectomy billing codes, the cutoff for the 250 grams, would you recommend weighing your specimen before sending it out or just estimating?
no, so estimating won't work. So you can either use the final pathology weight or you can weigh it in the operating room. I prefer to weigh it in the operating room. I have this feeling that the fixative decreases the weights, only because I've seen it a couple of times where I'll weigh it and then I'll see the post-op weight. And remember, this is only for laparoscopic surgeries. Open hysterectomies are agnostic to the weight of the uterus. They assume some will be big and some will be small. But yeah, if you think it's close to 250, I would weigh it in the operating room. Because again, if it was 252 in the operating room and you dictated that, that's the number you can use. If the final pathology says 249, that's the number you got to use if you don't have anything, you know, that justifies your billing code.
Thank you again.
You're very welcome.
Thank you so much for coming. You know, I'm trying to review our cases as a division every 3 months with our coders because I think it's really important to stay on top of it. I'm really sorry my partners weren't here because I'm sure they'd, you know, but I'll send them the slides and, you know, I took some notes and everything. So I don't know if anyone else has any other questions, but I think this is just really a great practical talk that everyone needs to be aware of, whether you're a trainee or you've been out, you know, doing hysterectomies for 30 years, because things are constantly changing and you got to pay attention to this stuff. Okay. I don't know,
Alrighty.
Dr. Ebert, is that it? Anyone else have any questions, comments?
All right. Well, Dr. Holtz, thank you so much for this excellent talk.
Well, thank you very much for the invitation. You all have a good day.
Thank you. I hope everyone has a productive and fulfilling day.